And I'm just going to give everyone a second to connect to audio before we get started. All right, it looks like mostly everyone is connected. Well, hello everyone, and welcome to today's virtual interactive panel discussion brought to you by the ACHE of Indiana. My name is Sandra McGarry, and I will be serving as your ACHE technical host for today. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the event. The chat function will be available for you, and we absolutely encourage you to use it. Please introduce yourself, let us know where you're from, give us some feedback on what you're hearing, ask lots of questions. It really does help keep the event interactive and helps everyone learn just a little bit more. This event is being recorded and will be available to you in ACHE's learning management system in approximately 2 business days. Today's session is worth 1.5 hours of ACHE virtual interactive education credit. And to earn this credit, you must be logged in for the entire 90 minutes of the event. All attendees who meet this requirement will have their 1.5 virtual interactive education credit applied within 2 weeks from today's event. We do encourage you to complete the evaluation. I will be placing the link in the chat box before we close out of today's session. So to begin, I am going to turn it over to the ACHE of Indiana Chapter President, Sheila Kelty.
Good morning. Thank you for spending your lunch hour with us. As Sandra said, I'm Sheila Kelty. I'm the chapter president for ACHE of Indiana. I would like to thank you all for joining us today for the behavioral health care approaches to increase the value for the organization and meet the community needs. Before we start the panelists, I wanted to take a moment to express gratitude to our chapter sponsors. So a special thank you to our platinum sponsors, Heapy and Ice Miller, and our gold sponsors, Arc Design, Cornerstone, Inn of Care, and Blue and Company. Support from these sponsors makes programs like this possible. Today, I'm also serving as the moderator for this panel. And we've had a slight change to our panel lineup from what we originally advertised, but I'm thrilled to introduce our distinguished panelists. Today, we have with us Stephanie Long, President and CEO of North Central Health Services, Danny Waddle, Director of Behavioral Health at Ascension St. Vincent Stress Center, Kimball Richardson, Manager of Business Development at Community Health Network. Each of our panelists brings a wealth of expertise and diverse experience to the field of behavioral health care, and I'm excited to learn from them today, and I hope you are as well. So without further ado, I'll turn it over to our panelists to give us a more lengthy introduction of themselves and share a little bit of their insight with their history and experiences. So Stephanie, if you'd like to step in and introduce yourself, and when she's finished, Kimball, then Danny.
Hi, I am Stephanie Long. I am the CEO and president of North Central Health Services. We own an inpatient freestanding psychiatric hospital called Riverbend Hospital, and that's my involvement with mental health care directly in the community in terms of services. We also have a significant grant mission that includes providing funding for initiatives to support mental health and substance abuse treatment in our community.
Hi, everybody. I see some friendly names out there whom I know, so please make sure I stay on track. I know you know Community Health Network very well. I'm Kimball Richardson, everybody. I'm a Hoosier, like many of you. And for the past 11 years, I've worked at Community Health Network, where I am the manager of business development for our behavioral health product line, which is called Community Fairbanks Behavioral Health and Community Fairbanks Recovery Center. This is my 37th year in healthcare, and I'm really, really happy to be with you guys today. And thanks for including me. And so nice to meet you, Stephanie, and get to see my buddy Danny Waddle again.
Well, hello. My name's Danny Waddle, and I'm the Director of Behavioral Health at the Ascension St. Vincent Stress Center in Indianapolis. I've been here for 23 years. I am a counselor by training and did direct clinical work here, primarily with adolescents with substance abuse and partial and IOP programs, and then also kind of general adolescents up through young adult. And some outpatient work as well. For myself personally, at the Stress Center, we have a variety of acute inpatient units and really have a big a wealth of partial and intensive outpatient programs at all different ages. Kind of a little bit of background for me and the Stress Center.
Thank you. And thank you to all of you who are putting your introductions in the chat. That's very helpful for the panelists to kind of see who's in the audience and what you do. As they answer the questions, they can take that into account. So the first question that we have for the panelists today is, how are you addressing mental health and behavioral health care in your organization? So Danny, you want to start us off?
Yes, I can do that. For me, for this question, I am the director of the Stress Center, which is the department of the hospital here in Indianapolis. Ascension Hospital in Indianapolis, if for those who may not know, is a pretty large hospital, one of the largest freestanding or the largest single hospital within Ascension, and then lots of things throughout central Indiana. And so my department is all behavioral health. So I certainly can talk about that one, probably will more later. But I wanted to highlight a few things kind of from the hospital perspective on this standpoint, as far as how we're helping to address behavioral health. Several things that we have involvement with, or that have been new in recent years, are increased screening, certainly in our emergency department, and then for all patients for suicide risk, obviously driven by national patient safety standards, but just implementing those things. Lots of great education to our associates on mental health and substance abuse, becoming a part of our standard education for annual education for all of our associates. The importance of diminishing the stigma around mental health, particularly mental health with patients who find themselves in the hospital, which is already a stressful and disorienting event. If I then also already have some mental health struggles on top of that, that's a big part of it. And then a big part of our work here as the behavioral health department of the hospital that has grown tremendously in the last several years is our consult service, having dedicated staff that are available to consult with our inpatient units, both the main hospital here and some of the women's and Carmel and Heart Hospital and some of the few places, the places around us in central Indiana. We have a behavioral response team, so different from that consult service where that's providers who are intervening for actual care. We have a behavioral response team, which is actually made up of supervisors from our nursing areas in the Stress Center, and they can respond to other behavioral health related needs for patients that isn't necessarily like a medical intervention. They also can be helpful and respond to family and visitor issues that might also kind of go along with some of those mental health things. And I think those are some of the big things that I wanted to start off with that question with, and go on. So the next, does that sound good for the first one? I think I'm watching my time, so.
Fine. Kimball, you want to talk to us about how your organization is addressing things?
Well, very, very similar, I would say, to what's happened at the Stress Center. And all my good friends over there are doing a great job. Since the late 1960s, early 1970s, Community Hospital at the time, and now Community Health Network, was dedicated to providing services to people who had a mental illness or mental health condition, including substance use. And in that time, we've grown to have two community, small c, when I say community, I have to say big C or small c, whether I'm referring to Community Health Network or not, but we own 2 small C community mental health centers, and we have inpatient services over 3 different locations. And one of the things that we're doing to address this need is we're expanding. And this was announced in the news about 2 weeks ago, but we are literally expanding acute care services for our brother and sister Hoosiers, or those who happen to be in Indiana at the time. We're going to partner with another organization to do that, and we believe that we will have 2 brand new hospitals within the next 1.5 to 2 years. So in addition to that, we probably get, not even probably, I'm going to tell you, I just checked on these numbers this morning, about 4,000 calls a month to request outpatient services, 4,000. And those are unique phone calls. It's not the same person calling over and over and over again. So we know that's a tremendous amount of requests for help. And we can provide most of those services, but it's important that we have partners as well. So we're homegrown. We started here in Indiana. We are not owned by a national company. We are owned by Hoosiers. And thankfully, we have leadership who believes in mental health services. Mental health services are difficult. It's complicated. The profit margins aren't very large at all. And the workforce shortage is real. So we face all those things, but even so, we're dedicated to pushing forward and making sure we provide services to more Hoosiers that we can.
Great, thank you. Stephanie, you want to talk a little bit about your organization and how you're addressing things?
Absolutely. Well, we're adult inpatient services only. So, we work to connect individuals, make sure that they have an appointment with an outpatient provider upon discharge. We also, while they are in the hospital, connect them to our local chapters of both NAMI as well as MHA. While those individuals those groups don't have providers, they certainly have some services in our community that can help support the individual and their family or significant others, as they transition back into the outpatient setting. And we've had a lot of robust discussions internally as well as to how we can impact behavioral health care in our community beyond the inpatient services. And one of the things we've talked about with many groups in our community is the importance of prevention services. And I think we all know that the data for the mental health of our youth in the state of Indiana is concerning. So a couple of things we've done. One, we launched what we call a Preventing Youth Suicide Initiative. And this is part of our grants mission that I spoke about. And we've provided a little over $1 million to 19 different school systems. And we partnered with the Education Development Center, which is actually a global organization that provides evidence-based programs. And they have worked with the schools to create a multi-tiered approach to preventing youth suicide. So it includes everything from actually developing protocols for helping students at risk, right? Sometimes teachers are worried about kids, but the school might not necessarily have something in writing to know what next steps do they need to take. Written protocols for response after a suicide, while the initiative's called Preventing Youth Suicide. I mean, we do know that suicides happen, and it's very important that schools have a process in place to respond. Help them develop community partners to ensure that students receive necessary support and services. So, okay, they identify an individual that's high risk. Again, they might not necessarily know who to reach out to help those students get the treatment that they need. And then just the ability to identify the student at risk, like a formal process for doing so. And it includes promoting protective factors that enhance students' well-being and engaging key stakeholders. That includes parents and school leadership, as well as just general messaging about suicide prevention and training for the individuals within the school. We did an initiative grant for this, and again, it's schools have the option to apply. The response was so strong with the first one, we opened up a second round, and we ended up having 19 of the 23 schools systems in our 8-county region apply. So I think that that's really indicative of what they feel is important and what they need. And we're really, we are encouraged with some of the early outcome results that they're seeing in terms of children that are identified and connected with treatment that perhaps otherwise maybe wouldn't have, especially in our rural areas where we know it's difficult, right, to have, there's certainly fewer resources available to them. And prior to that, we also did a prevention program or a grant that we called the Resilient Youth Initiative. And this was for schools to implement evidence-based prevention programs in their schools. So things that are proven to improve student behaviors, right? So less trips to the principal's office, or longer time, or less a shortened time in the principal's office to redirect behaviors and returning to the classroom. Increased attendance rates, improved grade, the overall grade that they receive in school, increased graduation rates. And again, we contracted with the same organization to work with the schools for a period of 3 years to implement these programs. And then they're doing ongoing evaluation and gathering outcome data. And again, same scenario, 19 of the 23 schools in our service area applied and received and completed that grant. So these initiatives really came out of our community health needs assessment conversations where we heard the school saying, we don't know what we need, but we need something. These children have been exposed to more traumatic events than perhaps they'd seen historically. COVID went on in the middle of this, and we all know that certainly had an impact on all of our mental health. So that's just another way we are trying to improve the behavioral health care in our community outside of just the services we provide as a hospital.
Do you mind if I tag on to that, Stephanie? You guys are doing, that sounds like an awesome program you have. And we also provide in-school services and programs. I did want to mention that, again, we're very lucky that we focus on education, the Community Health Network. We do provide, and we've started the second only to IU School of Medicine, the second psychiatric residency program in the state. That made national news, you guys, when we started about 6 years ago now. And I've been very fortunate to be connected with our program, helping to interview students. We're just in the rounds of interviewing for next year again, and we've increased from 4 to 6 slots for the residency, and the vast majority of people who started their residency with us are hired at Community Health Network or staying in Indiana. So that's fantastic. We are growing doctors for you guys out there. And in addition to that, we started an addiction medicine fellowship 3 years ago, and we just graduated our last 2 of this round. And one of them got hired on to stay and work at Community Fairbanks Recovery Center. So we have physicians out there looking for opportunities, and they love Indiana so much. Now when they come here, they want to stay. So please let us know if you're interested in doctors, we might have somebody that we grew for you guys.
That's great. Thank you. I apologize. I got kicked out of the Zoom and I'm made it back in. So thanks for continuing on without me. I also wanted to just remind the people that are participating that we are willing to take questions about what we're discussing, and we're going to do that through the chat. So if you hear Danny, Kimball, or Stephanie talk about anything that you have additional follow-up questions or comments about, please put that in the chat because that's the only way that we can know to respond to you. The next question that I wanted to ask is about how your organization approaches behavioral health, kind of the step-by-step process. So you gave us the higher level of what you do. Stephanie, you went a little bit into yours already in the in-depth related to the school systems and the youth prevention. But, when a patient comes in and enters your system, kind of what's the step-by-step, the process that you work through to care for your patients? Danny, you're on mute.
Yep, I was like, I can start on that, but I have to unmute. Yeah, I think I talked about the consult service and behavior support and those pieces. But switching to more on what we do here at the Stress Center and kind of how we interact there. The screenings when someone is first admitted and certainly coming through the emergency department is one way. One thing that we have done recently, over the last several years and really ramped up the last couple of years, we also provide crisis assessment to all of the emergency departments for our sister facilities. So any other Ascension Hospital in Indianapolis, we are doing those crisis assessments via telehealth if you present to those areas. So, rural areas that don't have access to mental health workers, we're helping to solution for that by doing that via telehealth from here, and then helping to facilitate a proper transfer to a closer facility if needed, or even to us in some cases. So certainly, one approach there. If you have lived in Central Indiana for a while, as I said, I've been with Ascension for 23 years. You might remember that there was a time where there was a lot of stress center outpatient offices around the city, and one of the things that took place in the early 2000s was some discernment around what do we do best. Kimball said earlier, mental health is hard. Mental health treatment and providing that and having those services is hard, and making sure that you're not losing a lot of money and those kinds of things is difficult. And around that, we really decided at that point in time to focus on the things that we knew that we did best. And that's our acute services and our partial and intensive outpatient services. And we really did for a long time focus solely on those pieces, continuing to grow them from where they were and already strong. We've diversified those program areas to where we have programming for all different ages. We have child, adolescent, early adolescent, young adult. We do focus on mental health primary as well as dual diagnosis, so that mix of substance abuse and mental health, and really are a dual diagnosis provider. I like to talk about, people get afraid to talk about substance abuse sometimes, but remember, it's just a chapter in the DSM. It's just another one of the mental health issues, and not as scary as it seems. They're all different. And so really focusing on that whole mental health, and that's just a piece of it. And then more recently, talk about schools. One of the places that we have, identified, where we don't have a breadth of regular outpatient services, but kind of getting back into that. How can we do that in a smart and strategic way? And we are now in our 6th year where we have also started doing some different school services. And we now have school counselors and behavioral health techs where needed that are embedded in our different partnerships with both Carmel Clay schools, Westfield, Washington schools, and starting this school year, Zionsville schools, where really the goal, the number one goal is make it easier. make it easier for kids to get therapy, make it easier for parents to access it. That's the primary focus there, and that, growing that, and it's a great supplement to our acute inpatient and our partial and IOP programs as well. But it's also a way to kind of venture back into that regular outpatient world in a different way, where we can partner with those schools and we can eliminate some of the barriers around making an outpatient office profitable and those kinds of things by entering into those partnerships to really focus on that access and helping to improve those pieces.
Great. How about you, Kimball?
Well, I feel really lucky to be at Community Health Network and to have a full continuum of care. And I hope you hear that I'm saying that with pride and not in a boasting way, because I know that we have a lot of psychiatrists, we have a lot of outpatient offices, we have all levels of care, just as Danny described, including outpatient regular. I want a person to talk to, and including all the intensive programs. The other thing that we offer also is, if you do have a specialized mental health need and you need in-hospital care, depending on your age, depending on your gender perhaps, or even your diagnosis, you can have specialized treatment in that way. Not everybody has a program that can fit that capacity. So again, thankfully, we have leaders that do believe in that, do believe in behavioral health care and allow us to expand those services. The one thing that we did in 2019 is to integrate our programs with Fairbanks Hospital. And Fairbanks Hospital, some of you know that name, it's very synonymous with substance abuse treatment. It was the earliest hospital in Indiana, a standalone hospital that provided alcohol and drug treatment, initially for men, later for women, and then for adolescents. And we also, at one point, hosted the only high school in Indiana that was designed to provide a sober high school environment for kids. So in 2019, we integrated, we're now called Community Fairbanks Behavioral Health and Community Fairbanks Recovery Center. So all the way from just, I need one person to talk to inpatient care, you have all that opportunities, and including all the grant things that are going on, like crisis outreach. We also are in about 155 schools, and we do have also a consult liaison team, and all those things are offered. But it is very tricky and complicated and difficult to keep it all running and going, as you can imagine.
Kimball, I think that when we talked earlier, you told me that your organization also helps with some emergency response, like for the hurricanes and tornadoes and things like that. Can you tell us a little bit about how that works?
I've been involved in crisis intervention my entire career. I am a licensed counselor in Indiana, and I am the coordinator of our district disaster mental health team, District 5 in particular, which is Marion County and the surrounding 7 counties. And I teach critical incident stress management. So we have an internal peer support team at Community Health Network, and I know that St. Vincent does too, because I helped to lead that team when I was there for many, many years. So we have about 80 people on our team. We provide it from all areas of the hospital, physicians, pharmacists, nurses, dietary, respiratory techs. I mean, any security, any single aspect of our healthcare organization has peer representatives. You have to have training, and you have to be on a team and be vetted and so forth. But if we have a critical incident, whether it's with one person or a unit or a department or several departments, we can literally dispatch a person from our team or members of our team to provide support to our own staff. So this is homegrown, and our leadership allows us to do that, allows our staff to do that on company time, or if they're hourly people and it's not on their work shift, they can clock in and get paid for that. So we have, I'll brag a little bit about our team. We have such a good reputation that we get asked by healthcare organizations in other states to assist them. And I don't think they would mind me saying that Tampa General Hospital contacted us a few days ago and said our staff is really hurting after the hurricanes, and yet we're still having to provide care to others. What can you do to help us? And so we got a team together. We're meeting with them literally today, this afternoon. Now, of course, it's virtual, but we're back to in-person meetings again. For a while, we were virtual, and we didn't do any virtual care prior to February 2020. And I don't know if you guys remember this, but in February 2020, the very first patient who had COVID-19 in Indiana was admitted to Community Hospital North. And man, I was at a conference that day when I got a page that had happened, and I'm telling you, turned real fast, because my wife also is an intensive care unit nurse at that hospital. So it got real personal, but we did a great job. We provided support and help to thousands of our own brother and sister healthcare workers, and it's been a great experience.
Yeah, that's great, Kimball. I know a lot of organizations, not only in Indiana, but throughout the country, really stood up teams like that to help with all of the mental health and the stress and the burnout that was occurring during COVID for their internal teams. And I think it was greatly appreciated. I know the hospital I was in at the time offered those services. And I know that myself and my team used the services that were provided within the organization, and, you know, coming into our staff meetings and those types of things. And coming from the other side of it, not your side of it, it's very much appreciated by the staff when those types of services are available internally. So speaking about our staff and how things are going in healthcare across the country, you know, we have all seen workforce issues over the last several years, and I'm sure that behavioral and mental health is no different than outpatient or acute inpatient medical health care. So can you talk to us about the workforce issues that your organization has faced in the last year and in the coming year, and kind of what you've been seeing and what you're doing about it? And yeah, Stephanie, if you can get us started off, that'd be great.
Sure. So we've experienced some of the same things all of you have, right? Certainly a difficulty with the number of RNs, period, in the community, but especially those that are interested in working in mental health care. It's a tough field, let's face it, especially from an inpatient perspective. Certainly, we've seen a provider shortage. We feel that especially when trying to connect patients to outpatient services within 7 days of discharge to the hospital. So we've kind of taken in, we're doing the typical things you all are doing in terms of recruiting, working with your nursing schools, etc. But we also took a different approach when looking at how can we have a bigger impact. Maybe we won't feel it immediately at our facility, but we do know a rising tide raises all ships, right? And I think Kimball mentioned how Community Health launched their psychiatric residency program, and that those individuals who complete that program, a vast majority are staying in Indiana. And we see that across the board, not just with the residency programs, but we see that in our nursing programs. We see that in our MSW programs. We see that in our nurse practitioner programs. So really since I think our first foray into trying to affect workforce in the state and particularly in our region as well was back in 2017. And in discussions with the Dean of Health and Human Sciences at Purdue University, you know, they have obviously a nursing program. We asked if they would be willing to launch a psychiatric mental health nurse practitioner program if they had grant funding to launch it, and they did. And, you know, that has continued to produce nurse practitioners directly back into our region, but really within our state. We support both the both residency programs, both the Community Health Network residency program through grant funding, as well as the IU School of Medicine psychiatric residency funding. Both schools, I mean, I have some of the statistics in front of me, right? Both schools can show that they are keeping around 50% or greater of those residents to practice when they complete their residency in the state. That's huge. And the IU School of Medicine psychiatry residency has experienced a loss of some funding, and they actually had to scale back from 11 general spots back to 8. So I would encourage any of you who are looking to have an impact on workforce in our community, think about some of these other ways to do so. We also provided 3-year funding for Indiana University School of Social Work to launch an MSW program here in Lafayette, Indiana. They'll be based out of the Ivy Tech Community College. That they're going to use that space, but it's an MSW program. And one of the barriers when we would talk to individuals about why haven't you gone on to complete your MSW? A lot of it was logistics, right? Many of them are adult learners. They have full-time jobs, they have families. And so we wanted to see how could we make it easier for them? What made it easier? Having something local. So we've really seen, and then we gave a significant grant to the Ivy Tech School of Nursing to expand their RN program as well. Now we know only a fraction of those will decide to work in behavioral health care, but again, it's the old rising tides raises all ships. And so one thing that's really there's been attention to it in the state of Indiana, right? So the Bowen Center for Healthcare Workforce Research and Policy recently released a playbook for enhancing Indiana's mental and behavioral health workforce. I'd encourage your organizations to take a look at that. We actually are mentioned in there for some of our work, but there's ways that are proven. Like if we can expand the opportunities for these individuals to receive their education in our state, it's proven that they will stay in Indiana and work. So that's maybe a different approach that we've had to try to impact the workforce. But yeah, I'd encourage everyone to take a look at that playbook.
Stephanie, that's some great work that your organization has done. Really appreciate you and applaud you for that kind of work, focusing on, you know, getting people trained and available to be in the workforce. Danny, what's your organization experiencing related to workforce issues?
Yeah, you know, certainly the same as everyone. I think particularly the larger difficulty for us is certainly that counselor role, counselor, social work, marriage and family, you know, regardless of the background. From a counselor perspective, we take folks from all of those backgrounds and all of those different licensures in our counselor role, but that's getting more and more difficult to find. You know, as mentioned already, just having them educated and available, period, is an issue. I think there's you know, a large draw for folks to kind of get into private practice, get into the spaces where they think they want to be as a counselor, and certainly we need that, but certainly our systems and our higher levels of care need more folks too. And one of the things we've really seen recently is a I will say a turn almost to the negative side of students and practicums and internships and folks, and we've seen a real kind of dwindling of the numbers of students that we're getting. Because while programs are ramping up and trying to get more people, I think they're also being challenged by the the need to please their students and make things convenient for them. And what we're seeing is a lot of students wanting to choose to go into internships that offer virtual and offer, more convenient things, which is great. But it also doesn't necessarily expose you to some of the more serious mental illness and some of the more, robust things that you'll learn by working in a system. And we have a wonderful student program here for folks in the counseling fields. I was a student intern here 24 years ago this January, which turned into a career. I would say probably about 60% of our counselor workforce are former students with us. And so we have a huge advantage when we were able to essentially see folks for a year and really train them and shape them and keep on those folks who are doing wonderfully. And while we still have that, where we would have 15, 20, as many as 25 students in a semester, sometimes now we're struggling to get commitments to 10 or 12 of them. And it's one of the biggest things that we're hearing from them is that they're wanting more convenience in their practicum and their internship. And while I hear that, convenience doesn't always teach you the things that you need either. And so, certainly focusing on those relationships with the schools and building that up and why we're here. And every single semester we have students who go back to their internship classes and they talk about all their friends who are in these nice convenient places where they're doing internship from home and virtual and this and that, and they're seeing 2 patients and they're seeing 3 patients. And I guarantee you that the students that are at Community, the students that are at Ascension St. Vincent, they are getting a such more well-rounded experience and exposure to things that will prepare them for careers in a much better way. And so focusing on that. And then secondly, I'd say focusing on that training and orientation and training and onboarding, and really those first few years while people are here, and focusing on trying to develop people for their careers, and knowing that some of those are going to leave us and they're going to go out. We've created, this is now 15 plus years ago, but we now have several folks in this role where we have float roles that are folks who cover all the different areas of our hospital, partial and IOP and other areas. And predominantly those tend to be those new grads getting those preliminary licenses, and they get 2-3 years of work where I get to see kids today and adults tomorrow and substance abuse today and mental health tomorrow. And those roles shape folks to where we see people going into that permanent kind of their real role later, or leaving us and going somewhere else, which is totally fine too. And going into areas that they never thought they would go into during their education, but because they were exposed as an intern or as a float counselor or something else, they find that. And lastly, I'll say the biggest area is not just in the mental health, the counselors, the need, but particularly counselors with youth. And so that, is another big struggle for us, and certainly working on, how to develop those folks and encouraging folks early in their careers to get a variety and do that. Another big thing we've done in the last several years that I've seen huge success with is how are we providing our supervision to those folks that are earlier in their career, or even our mental health clinicians and other folks like that. And we've put new processes in place for different types of supervision so that you can have someone who's helping you grow as a professional counselor who isn't your boss, because that's super important, I think, to develop a well-rounded person in the mental health field.
Thank you, Danny. That's great. I really like that last comment about having someone that can help you grow in your career that isn't necessarily the person that you report to. That's really great. I'm going to go a little bit off script now before I let Kimball answer, and I have some follow-up questions for you, Danny. So I know you talked about related to the workforce and the development of your workforce and how virtual maybe isn't always the best for helping your workforce. But when you think about accessibility for your patients, and I know Stephanie and I both originated in a rural healthcare setting in different parts of Indiana. We have a lot of rural areas in Indiana where accessibility to the counselors, that very first entry level of kind of prevention, if you will, as it relates to mental health and getting patients just that person to talk to. I think we've seen a lot more accessibility by using virtual in counseling. And so not through workforce development, but just the accessibility side of it. How do you see the virtual piece? Is it positive, a negative? Is it neutral?
Yeah, definitely, changes there, and like you said, different from development of newer staff or students, but like the accessibility piece. For sure, being able to cover our remote emergency departments through telehealth, super helpful. In our schools and in some of our areas where we have some of that regular outpatient, we do have a fair amount of virtual offerings too. Particularly our school services are year round, but during breaks and summers and things like that, while they're still in the schools and available, they do a lot more virtual. So staying connected to folks during breaks and downtimes, using that virtual platform for certain. We have, some of our partial and intensive outpatient programs. You can utilize a virtual appointment for your med management appointment. And so there are places where even with those higher levels of care and those kinds of things, that certainly fits different, or fits for us in those levels of care that wouldn't necessarily lend itself to virtual all the time. In fact, although we did for a period of I think about 3 months, we did virtual services for IOP during the pandemic, but that was a kind of meet what you have to do there. It wasn't perfect, but it kept the program going for a while. But definitely where we can leverage our size and our ability to reach those rural communities for some of our services, and they do match with that virtual platform, we are absolutely kind of able to do that and pushing for more of that when we can. And definitely in that regular outpatient setting, the virtual services is just amazing to be able to bring that ease of connection and to a therapist and being able to do that, and that's wonderful. So hopefully your counselor is just someone who got a lot of live experience first and didn't
Okay,
just
great.
do virtual all the time.
Thank you. So Kimball, back to the original question related to workforce issues. We want to talk about that. I know you've told us a lot about your different programs with the residency programs and things like that, but kind of in general, your workforce issues, what you've seen and how you're addressing those?
So Sheila, some of our leadership was very forward thinking a few years ago and started something called the Behavioral Health Academy. And the Behavioral Health Academy is a way for for students, graduate students, to have a pre-degree experience, sometimes called a practicum and an internship, at a community mental health center that offers that full continuum of care, that also provides people an opportunity to become dually licensed, either as your original, perhaps, license that you want to hold could be mental health counseling, could be marriage and family therapy, or could be social work, in addition to combining that with an addictions counseling license. So in order to do that, you have to have a certain amount of hours in certain areas. Danny, I'm sure, and Stephanie know that too. And so this experience offers that. So it's a pipeline for Community Health Network to watch young professionals grow over a year's worth of time, and to find out, hey, let's have a relationship. Do you like us? Do we like you? And see if it's a good fit to having them stay for ultimately employment. In addition, and I don't know about your particular profession, Sheila, but I know, at least in my day, when I was doing my practicum and internship, that was on your own. You didn't get paid for that. you did it for free. And that's been the history of our profession for years and years and years, until recently in the Behavioral Health Academy, they do offer some, at least they did. I need to figure out where we are now, but they did offer some loan remission and some fee, and they paid students to attend. So that was a pretty cool thing. It was a really big difference from where I know at least Danny and I started in our career. And I love what he said about having people have a breadth of experience. I'm going to say a word, and some of you are going to know what I mean. Wishart Hospital. Well, that's 2 words, I guess, technically, but okay. Wishart Hospital. That's where I started my career. It was the best, worst job I ever had. I got so much experience. I was so overworked, but I didn't care. I loved it. I still am friends with those people, 37 years ago. And it's much better to start your career, in my opinion, with being exposed to different kinds of mental illnesses, substance use, all ages, all people from all different cultures and backgrounds, economic, all the stuff you can think of that help us help humans who we are. And so you get that experience in those kind of capacities. So good for you, Stephanie and Danny, for offering that to students too.
So the next question I have is related to health disparities. Can you talk about how you are addressing health disparities as it relates to behavioral health, and how you measure the impact your strategies have on the community?
Do you have a place you want us to start? This one I can start. And having the questions ahead of time, I still wasn't quite sure how I wanted to come at this one, because this is a big question, right? I think the biggest place for us is just in that identifying, right? Like a huge disparity with mental health is the fact that we just ignore it. Like we show up at our primary care office and, you don't think about suicide, right? Like we put in these screening questions, but we don't ask them in the right way. We ignore it. We still have huge bias, even our healthcare workers. There are a ton of healthcare workers out there in the world right now that still think that, substance abuse is just a choice. Mental health, pull your bootstraps up, just get better, right? Like how are the people that are caring for our health, if that's where they come from, a space of not being educated correctly in mental health and substance abuse issues, and living with these bias, then we ignore it, we treat it poorly, we make it worse, right? If we do address it. And that's the history of how we handle mental health and healthcare. So certainly the first disparity is just acknowledging it and knowing that it's a part of the whole person and a part of that picture, right? Certainly as a Catholic healthcare organization and serving a community, we have community needs assessment, and of course behavioral health is always going to be high on that. Education, support for schools, always going to be high on that, and certainly have a huge charity care and community education and community related things as a system. So certainly doing those things, and lots of that absolutely comes with some measures and some other things like that, all of which are above my pay grade. So I'm going to say that first. So as a huge system, that is certainly important. But I think how we do it at the local level, if you will, or even within the stress center here, is that we're here for all patients. Regardless of your ability to pay, we are going to figure out how to make sure that you get the care that you need. So that's the first place. And then, looking at knowing that we're a religious hospital, not a community mental health, not attached to community mental health center, not those pieces, knowing where our piece in the pie is, and then working with other community mental health centers and other resources in our area to make sure that where that patient that might not fit for what we have from a service perspective for mental health care, but partnering with those other agencies in the community to make sure that we connect them there, I think is another huge piece of that. And then, just supporting and advocating the mental health system, as a whole, and working with our partners to make sure that it gets the attention that it deserves, and that everyone can continue to try to chip away at those biases and those other ideas that we have about mental health that are just wrong.
Thank you. Kimball, would you like to add to that?
Well, since we have a little bit of a bully pulpit right now with your audience, I would like to add to that, which is I would challenge you all to not make any decisions about your healthcare organization without first thinking about behavioral health. Let me say it in a different way. Include behavioral health in every single decision you make. That's my wish and dream. That's been my passion for 37 years. And frankly, when I used to say that, it would be Pat Kimball. No, you're not at the big kids table yet, But I think in the past 5 or so years, we are important. We've always been important, folks. You know what I mean. But I think we're recognized. We are taken seriously. And I'm thankful for that. So thank you all for also remembering to consider behavioral health as one of your important partners and service lines, hopefully.
Stephanie, anything to add on this?
Yeah, sure. Similar to what Danny explained in terms of financial assistance, et cetera. We are the only nonprofit inpatient psychiatric hospital in our region. So we're a bit of a safety net, and we certainly feel that. And in addition to the standard financial assistance policies, we also we don't send anyone to collections. We truly have a patient base that does not have the ability to pay for the most part, for the vast majority. But secondary to that, again, looking at our other arm and our other mission in terms of our granting, there is most definitely health disparities as it relates to behavioral health care among, just other general health disparities, right? And we are in Purdue University's backyard, and they have what's called a health equity initiative. And Dr. Jerome Adams leads that initiative. You may know Jerome as the former Surgeon General for the United States. He served during the COVID pandemic. He also was a former health officer for the state of Indiana, and we're fortunate enough to have him spending some time here. And in just general discussions with him, it's really a unique time period because the state has provided the Health First funding to the county health departments. The counties had to opt in to receive it, but really putting some additional funds in there to try to impact the health of our communities. And we know that behavioral health care is a part of that. As you mentioned, Sheila, our rural counties really feel the lack of mental health providers in the community. So we are working with Purdue's Health Equity Initiatives department. We provided them with $1 million a year over 4 years to do nothing but support the county health departments in our region. So in terms of how they can best utilize this Health First funding and help them collect outcome data. So really all it is, it's like a just pure support to the county health department from an area that has experts in the field. So these rural county health departments, some of them maybe have 1 FTE, maybe they have 1.5 FTE. Now keep in mind, they have to do all the routine things that are required by county health departments. They don't necessarily have someone that has expertise in data analysis. And so what our goal is with this initiative is that the Purdue Health Equity Initiatives Department could provide that assistance and data analysis to help them determine where are the gaps, help them look for evidence-based programs then to impact the gaps that they identify. Essentially be their assistants, if you will, but assistants that have a vast amount of knowledge in particular in public health. And so that's just another approach we're trying to take to address disparities.
Thank you. Sounds like some great work. When you think of disparity as it relates to behavioral health, you know, a lot of times there's a lot of focus and push on veterans or homeless, addicted people. And I know that you've talked a little bit about some of these initiatives and things that you've been doing. Are you seeing that in Indiana that we're having an impact? These strategies that you're using what's the impact that you're seeing coming out of these for some of these groups?
Well, I think the most recent Mental Health America study that was just released shows improvement in our youth statistics. Now, we certainly have a ways to go, but we know this is a marathon. It's not a sprint, right? But we're beginning to see some improvement. And I really think that's due to some of the focused effort that you hear, you know, each of us talking about today, as well as some other initiatives. So yeah, I think that we are starting to see some initial movement now. Time will tell, and we certainly don't want to ease up on the gas pedal just because there's some limited movement. That just means we need to push all the harder. So yeah, I am actually slightly encouraged with what we're starting to see.
Good. Kimball, how about you?
Well, one of the things we've been very fortunate to do over the past probably 20 years is to be very closely aligned with our first responders and those who are seeing our patients or soon to be patients pre-hospital environment, so that we can help them decide, help the first responders decide what would be the best option for this patient at this time, where could they go right now, and how can they get there safely. And one of the ways that we've been doing that, and I know Ms. St. Vincent works with these folks too, is called the CIT program. CIT stands for Crisis Intervention Team. It's an internationally based program that was started in Memphis, Tennessee in the late 1990s. It first came to Indiana in the late 1990s, early 2000s. And just this past August, the International CIT Conference was hosted for the very first time in Indianapolis, Indiana. And I know this because I was part of the conference committee. They had their biggest conference ever, close to, not quite, but close to 2,000 people were here. And I think, no, I'm sorry, it was close to 20,000, pardon me. It was close to 20,000 people from mostly the United States, but from about 10 other countries. And what that helps with is our first responders are understanding that behavioral health issues, just like what Stephanie and Danny said, we're trying to destigmatize it. We're not trying to just blow things off. We're trying to get people the help when they need it, where they need it, and how they need it. And that's been very important for us to do with our surrounding counties who participate in those programs. So we offer part of the training. Even some of our residents go in and talk about psychopharmacology to first responders and how you can tell, perhaps based on the medicine's name, what someone's diagnosis might potentially be, or what part of a prescription bottle is important to read off to the hospital as you're coming in. You know, just practical things that are helpful to know. In addition, we are also helping to teach first responders how to use some of the screening instruments that we also already use, like the Columbia Suicide Severity Rating Scale. So it's been you won't be surprised, it's not been easy. This is a difficult. The first responder culture doesn't naturally come to behavioral health professionals with open arms. It takes a minute to get trust and to understand each other. But I think that's really improved in the past 5-10 years or so.
So Kimball, with these programs that are in place, how is that positively impacting the community as a whole by having these first responders trained this way?
It ends up being either the second or third largest referral source for our crisis department. So they're recognizing when something needs to be dealt with and taken seriously. And I would say nationally, people who come to a crisis department from a police law enforcement agency, there's about a 30 to 35% chance that someone is going to be admitted to an inpatient facility based on that. In our facility, over the last several years, it's been about 50%. And I see that as a good thing, because I see that as our first responders are more educated, they're more in tune with what's happening with someone, and they're correctly getting people into crisis and into care when they need it. So yeah, it's about a 50% admission rate from when people come in from first responders.
Great. That sounds like it's making a huge impact.
It's a
Do
big
you,
impact.
anything else that you would like to add about the impact of some of these programs and strategies on the community?
Yeah, I don't have the numbers right now, but one of the things that we also have been a part of now, we're in our second SAMHSA grant related to zero suicide. And I know the number is in the thousands or like tens of thousands of free QPR, which is question, persuade, respond training that we have provided to individuals in the community, several school systems, other large employers, but through that grant team doing that it's frontline mental health kind of first aid type response that anyone can go through for free. And so that certainly has had an impact just in the sheer number of people that have been educated with that. But then the thinking is the more of us that are educated in that way, you're reducing the stigma, and then part of that process is helping people connect to care, if and when needed. So no concrete data there on that, but certainly a huge impact that I know for sure in that way.
Thank you. We have about 20 minutes left, so I'd just like to remind the audience that if you have any questions, please put those in the chat. Also note that if you don't have your chat open, Stephanie has given you a couple of links. To one of the links is to the Bowen Health Workforce Playbook that she was discussing, and another one is to some initiatives from the North Central Health Services. And then Sandra has also put in the evaluation that ACHE provides for you to fill out. So please open your chat and take a look at those types of things. The last question I have for the panelists is, how would you define success in addressing mental health issues in Indiana? And if we look ahead to the next year, what specific positive changes would we expect to achieve in the next year? I know, Stephanie, you said it's a marathon, not a sprint, but how could we also hold ourselves accountable to achieving these specific aims over the course of the next year? And maybe, for those in the audience, what can they do in their organizations to help our community and our state hit these positive things that we want to look at related to mental health issues in Indiana over the next year? So Danny, I'll let you get started on that one. I know there's a lot in there, so you can for us.
I kind of got a little, you got a little warbly there, they're cut off at the end. So if probably my feed, but if I cut out, let me know. But I got the gist there. Well, I have the question in front of me too, right? So, how would I define, for me, I'll go more, macro deciding, success for mental health in Indiana. I would define it as, if you want mental health care, you should be able to pick up the phone and find it easily and get scheduled within a reasonable amount of time. That'd be the first place I'd start, is just that accessibility, and then how are we able to access any level of care, but particularly just accessing in general. I think positive changes that this group could aim to achieve. I'm going to take a different route here. I know, we're here talking about how are our different systems addressing mental health needs, and we're primarily looking at patients, that we certainly talked about workforce, but that's where I'm going to go with this question is how are you taking care of the mental health of yourself and your employees and the people that work with and around you? And I think that, is a place that we can all start making sure that our own, have access to good benefits, have access to, crisis response, like Kimball talked about, that both Ascension and community have for our folks, EAP services, that we have for our folks, where you can specifically get therapy, not just that kind of helpful response. And so, how are we taking care of and looking out for the mental health of ourselves and those around us? Because if we're not taking care of ourselves, we're not able to be there fully for patients either. And I think that as employers and as leaders and the focus on that for our folks is a great place to have a huge impact. Certainly there are all kinds of other, legislative and social issues and all those things that we can do as individuals and as organizations, but really, if you focus on that group of people around me, the people that are taking care of patients, but making sure that they're taking care of themselves and they know how to access things, I think is a great place to start.
Thank you. Kimball?
I'm going to roll with what Danny said, with whom I totally agree. And I've had the honor over these past 5 years of working on some grants, national grants, HRSA grants, Healthcare Resources Administration, and several of my colleagues that have been interested in resilience across the country. And I wrote a workbook that got published last year on resilience. And it's free. We are, because of the grant, we're not even allowed to make money off of it. Okay, so I'm proposing it and I'm pitching it to you, but I think it's something that's helpful to remind people about self-care. And it's something that literally just recently came out. It was published in 2023, but not it's just kind of getting out and about at this point. So if you're interested in having something like that for your healthcare network, please let me know. Contact me. I put my information in the chat and I'll send you a free link that you can download for free. I think you do pay a small charge if you want a hard copy, but you can download it for free. And then you can use it as you'd like. It's self-guided, or you can have other people tee it up for you if you'd like. I literally about 2 weeks ago made a pitch to my own organization about how we can use this workbook to keep our own staff resilient and focused on self-care. And it just reminds me, 2 o'clock today, we're helping our brother and sisters down in Tampa Hospital to maintain their resilience so that they can be there for their constituents as well and patients. So that's important.
Stephanie?
Yeah, I think much to what both Danny and Kimball have said, I have very similar thoughts. I think just when someone's in need, knowing how to access the behavioral health care system. The amount of, I field so many calls from friends or former coworkers or acquaintances, right? Who say, hey, I've got a brother, I've got a sister, I've got a son, you know, they're experiencing a mental health crisis. What should I do? Where should I go? People don't feel quite the same way when you're experiencing a medical situation, right? You know, you have a primary, we know to start with primary care. There's urgent cares, there's the emergency rooms. And while we have some of those systems in behavioral health care, I think they're not as well known. We don't talk about them as much. So I think for me, when I think about what does success look like, some of that ambiguity or the stress of not knowing how to even reach those services is gone. I also think that we need to do a better job, because there are resources that are, you know, limited resources, of pulling together everything there is to support this individual, utilizing other nonprofit support organizations such as NAMI and MHA to provide additional support for these individuals and their families and their loved ones, to really try to wrap it around. You know, we all know healthcare is siloed. I think behavioral healthcare is even more siloed, some of it driven by the increased HIPAA regulations, which are certainly there for good reason. But I think we just have to really, you know, look at the way we're providing care and make it easier.
Had to find my microphone button. So really what I heard from you, from the three of you, is number one is making sure that all of the residents of Indiana know a very easy way to find out what services are available and how to access those services and be able to get those services at their time of need. Secondly, making sure that as employers, we are making services available to our employees. And then thirdly, making sure that we're providing opportunities for resilience and self-care within our organizations. So in looking at those three things, the one that I find, you know, probably the most interesting is, how do we get the word out to the citizens of Indiana? Just, you know, the general person on the street, hey, when you need mental health care, here's how you can find out what resources are available to you. So do you have any thoughts of how we could do that in Indiana to make sure that every single citizen of Indiana knew how to get that health care when they need it? So I see Stephanie giving some yes here. So we're going to start with her.
Couple of things. I think 988 helps. I think that's certainly the right track. As with any newer program, you know, we need to keep working to hone what it's, you know, the way that it's operated and the way individuals are directed. We also piloted a program in our community through Mental Health America. When I said we've got a coalition of mental health care providers and nonprofit organizations that meets in our community on a regular basis. And we piloted with some funding from a group of us, including United Way, what was called a Navigator program through Mental Health America. Now, Navigator gets a little bit confusing for those of us in the healthcare world, because that's also what we call individuals that help sign up for insurance, right? But it's a number that's manned 24/7 that an individual can call, and they can help find them services or connect them with services. So that individual that says, oh my gosh, you know, something's going on with my loved one or with myself individually, pick up that phone and they can help, you know, lead them, guide them down that path, can actually help provide them with transportation assistance. In certain cases, we know that's a barrier. Certainly. So I do think we have a couple of things going on that are show promise, but we need to continue to put resources into that.
Kimball, any thoughts?
If you ever have an opportunity to go to an elementary school and talk to our young leaders about what does it mean to be a counselor or a social worker or a psychologist or a mental health professional or a substance use professional, do it. Because they're not going to know even what that is potentially an option. You know, when I was younger, thinking about a career, nobody told me about, well, you could be a psychologist, Kimball, or you could be a mental health counselor. I found out about it on my own. Okay, but if someone had planted that seed in me as a young child, even the possibility, I think we'll get more people in the profession. And you just start talking about behavioral health more and more. And it starts with, you know, it's not a quick result, but and I think it'll pay dividends long term.
Great, thank you. Danny, besides 988, any ideas how we can get that word out to people about how they can access services?
Yeah, I would encourage you if you are a provider or if you are leading a provider group or, wherever you fall in that spectrum, as a person within the healthcare field, I'd ask you, who are your referrals? If you have someone that you know that needs mental health services, where's your list? We should all have one, right? We should all, this healthcare is about relationships in general, but mental health care especially. And as a professional, a person in the healthcare field, I feel like that we should all find out what the local resources are and make those connections and find those relationships so that you've got a short list. 988 also great, wonderful. Like I can call that anytime. Anyone can do that anywhere, but they're also just working off a list. And the more that your patients will engage in what you ask them to do is going to be more likely if they feel like you had a personal connection, if you're giving them a referral that you have confidence in. And so, we can on an individual level impact that by knowing those things and finding that out. And if you don't know for yourself, ask a colleague, ask around, find somewhere else. We all should have that personal list.
Thank you, Danny. That's a great idea. I really appreciate that thought. So that is the end of our question and answer. And so Corey has placed in the chat a link for our upcoming Indiana ACHE events. If you want to look at that to come to some of our additional events, we'd be happy to have you. I would like to thank everyone for joining us today. A special thank you to our incredible panelists, Stephanie Long, Danny Waddle, and Kimball Richardson, for sharing your valuable insights and experiences with this group. We truly appreciate the time that you took and the knowledge you have. Again, thank our sponsors, TP, Ice Miller, Arc Design, Cornerstone, InnovCare, and Blue & Company that allow us to make these programs possible for you. And then to our participants, thank you for being here. Your continued dedication to advancing behavioral health in your organization and your communities is important to us. So I just want to urge you to keep these vital conversations going and continue to make a difference in this area of healthcare. Before I hand it back over to Sandra, I want to remind you that registration is open for our Indiana ACHE annual awards and our 25th anniversary reception. It's being held on November 14th at the Westin Hotel in conjunction with the last day of the Indiana Hospital Association annual meeting. We are also offering additional opportunities to earn qualifying educational credits and in-person credits at the Indiana Hospital Association annual meeting that's on those same dates, February 14th. And then we've also added one more in-person education credit this year in November, on November 20th at Fairbanks Hall. So again, look at that link that Corey sent, go to our LinkedIn page, watch for your emails from the chapter to be able to get into some of these important educational opportunities. So Thanks again for your participation, and I'm going to turn it back over to Sandra.
Great. Thank you so much. On behalf of ACHE, I just want to thank our chapter leaders that planned today's session, our moderator, the panelists, and all of you for your participation. Please complete the evaluation, which is open for 1 week. I did place the direct link in the chat box for you, but you can also you can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the helpful link section on the right side of the screen. From there, you can click on Access My Courses, where you'll be directed to our learning management system and you can complete the evaluation. In that same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of virtual interactive education credit posted to their My ACHE account within 2 weeks of this session in your My Education Credit section. That does conclude our session, which is copyrighted in 2024 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone.